Hi guys, good evening, good evening, good evening. I'm Dr. Sandeep, your surgery guy. So today we are back again with our BLS series. We've been talking about the goiter. I hope you guys are joined up. Alright, so today's topic that we'll be discussing is a very important topic, that is going to be goiter. So what is this goiter? Why does this goiter happens? What leads to this? So we're talking about all the important components that are going to be around this particular topic. Hi Rahul, good evening. Good evening guys, good evening, good evening. Everybody's tuned up, pumped up. Can we start? See, the caption of these topics are slightly changed, so I will rearrange them. Hi Snehajit, good evening guys, good evening, good evening. All the guys who are joining up right now, we are doing the goiter for today. We'll try to understand how the goiter is formed, what is the pathophysiology behind it, what is exactly goiter basically means. So without wasting any further time, let's kickstart the discussion on goiter. So when I say the word goiter, what basically goiter means, it is a generalized enlargement of the thyroid gland. The word goiter is a generalized, this is a generalized enlargement. This is a generalized enlargement of the thyroid gland. Now when I say generalized, that means the entire gland is going to get enlarged. That is going to be in a uniform manner. Yogesh, good evening guys, good evening. Take care. Chalo. So we'll be talking about why is this generalized enlargement occurs in the thyroid gland, right? So we'll try to understand the basic causes for the goiter. We'll be talking about initially how a particular thyroid gland converts into a thyroid swelling that is called as goiter, and then it translates into different forms of swelling as well. Right. So let's begin with the causes. So when I say the causes for goiter, I can divide them into two categories. That is a physiological goiter. There's going to be a physiological goiter and a non-physiological goiter, right? So causes that results in a physiological goiter and causes that sustains as a non-physiological goiter. Now, example of where a patient will experience a physiological form of goiter, it occurs whenever the demand for the hormone increases and the supply is inadequate. To compensate for that excessive demand, the body will start enlarging the gland so that it can produce more amount of hormone. When would you have this increase in demand? The increase in demand is there during puberty, and the same increase in demand will also be seen in pregnancy. So you will see during puberty and pregnancy, it might get enlarged. So this is a physiological enlargement. It will revert back to normal once the things are back. That means when the puberty subsides and when the pregnancy is done. We are more interested to understand the non-physiological forms of the causes of the goiter. In this, I can divide them into two categories. One is the primary iodine deficiency. Another one is the secondary iodine deficiency. One is the primary iodine deficiency. Another one is a secondary iodine deficiency. What is this primary? What is this secondary? Is anyone facing a problem with the voice? Priyanshu says voice is not clear. Voice has an echo. Shouldn't have an echo. Check now. Is it okay? Is it okay? Just check if the voice is fine now. So the primary iodine deficiency and the secondary iodine deficiency, right? All right, okay, great. So when we say a primary iodine deficiency, we know the daily requirement of the iodine. We have been discussing this. What is the daily requirement of iodine? The daily requirement of an iodine to keep you euthyroid is going to be 0.1 to 0.15 milligrams per day. This is 0.1 to 0.15 milligrams per day is your daily iodine requirement. If you're not taking this iodine on a regular basis, that means you're not able to take this daily requirement, this will result in the goitrous state. So you say where the iodine intake is reduced. The iodine intake, whenever is reduced, it will result in primary iodine deficiency, which will now translate for the development of the goiter. Now, when you say a secondary iodine deficiency, now this is interesting. In a secondary iodine deficiency, you say patient says that iodine intake is normal. The iodine intake is considered to be normal, but the iodine uptake or utilization, by the follicles are reduced. By the follicles or the thyroid follicles, they are reduced significantly, right? So we say the iodine intake, that means when the patient says, daily requirement is this much, that daily requirement of iodine is being taken, but the follicles are not able to utilize it. The iodine uptake or the utilization by the follicles are reduced. Now, why or when does this occur? So when you look at the whole context of this, why would the iodine utilization will reduce? The iodine intake is normal. Patient is consuming what is the daily requirement, but this is not getting utilized. So when you look at this, the basic causes behind this, one of the most important cause that we can talk about of the secondary iodine deficiency is goitrogens. Now, examples of goitrogens are your Brassicaceae family member. Now, these are the food substances. Example like cabbage, turnip, tulip and all that. So we say eating excessive amount of cabbage can result in a goitrous status or a hypothyroid status. So why does that happen? Now, in goitrogens, they produce a small compound which is called as thiocyanate. In a very small quantity, they produce a compound which is called as thiocyanate. The effect of the thiocyanate on the thyroid follicle is, if you take this as a representative thyroid follicle, I told on the surface of the thyroid follicle, you have this specialized ion-gated channels which are called as the sodium iodine symporter. Now, if the iodine which you are consuming will be taken up by the follicles, the iodine that you are consuming, it will be taken up by the follicles, it will be delivered into the follicles, it will synthesize into hormone. This is what we have been learning. Now, these goitrogens which are producing this thiocyanate will go and block. It is going to go and block the sodium iodine symporter. If the sodium iodine symporter is blocked, the iodine cannot be utilized. Even though you are consuming good amount of iodine, you are taking a normal amount of iodine, that iodine cannot be utilized. It is like you have done all that is required, the end point has not been there. That last push, what is required, it is not there. So hence, the iodine is not able to go. So it is like the same thing. No, you went all the way, right, to the temple, but दरवाजे बंद है. ठीक है, मंदिर तो चले गए, दरवाजा नहीं खोलोगे तो दर्शन कैसे करोगे? सेम वही बात है कि आयोडीन खा तो लिया, चला तो गया, फॉलिकल का बोलता है कि भाई आज जो सोडियम आयोडीन इंपोर्टर के दरवाजे हैं वो आपके लिए बंद हैं. किसने बंद किया है? ये आपके थायोसाइनेट. थायोसाइनेट कौन निकाल के लेके आता है? ये आपके ब्रासिकेसी फैमिली में. सो गोइट्रोजेंस, the goitrogens is food substances that interfere with the iodine absorption by blocking the sodium iodine symporter channel. As simple as that. तो एक प्रॉब्लम आपके goitrogen से होगी. दूसरा हो गया, it is going to be because of dyshormonogenesis. It is a dyshormonogenesis. Now, what is this dyshormonogenesis? You remember I told you we have a super hormone or a super, I would say, an enzyme which was catalyzing all the reactions. That is your thyroperoxidase enzyme. Deficiency of thyroperoxidase enzyme is what we call as dyshormonogenesis, right? You are taking the iodine, now the iodine is going into the follicle also, but inside the follicle, the iodine is like, okay, क्या करें? कुछ नहीं, है ही नहीं काम कराने के लिए काम ही नहीं, आपका टीपीओ आ ही नहीं रहा. जब टीपीओ आएगा नहीं तो फ्री आयोडीन, हाउ विल इट कन्वर्ट इनटू फ्री रेडिकल आयोडीन? हाउ विल इट कन्वर्ट इनटू, और इट विल रिएक्ट विद द टायरोसिन एंजाइम? हाउ विल इट फॉर्म इट एन ऑर्गेनिक कंपाउंड? हाउ विल इट अंडरगो कपलिंग रिएक्शन? इतना काम पूरा टीपीओ ने कराना. टीपीओ ने बोलता मैं हूं ही नहीं. जब टीपीओ है ही नहीं तो काम क्या करोगे? तो आयोडीन बोलता मैं तो वेला बैठा हूं. ठीक है. So problem here is in goitrogens. One, it is going to block the sodium iodine importer. Even if the iodine is able to go inside, if there is no TPO enzyme, it is useless. And then you have certain drugs. Example like amiodarone. Examples like amiodarone. These drugs also interfere with the iodine absorption. Okay, so hence they will now result in goiter status. So now we understood the basic concept of causes that can lead to goiter. We'll tell you how it is going to happen. One major cause is a physiological one, where you have the demand is increasing physiologically, but the supply is not being compensated. Example like puberty and pregnancy, it will revert back. So if a physiological goiter comes, I'm like, okay, cool, no problem about it. But if you have a non-physiological goiter, we'll say whether the patient is consuming normal amount of iodine or not. If he's not consuming it, he will convert into goiters, and that is the basic concept of your endemic goiters. All the guys who are going to have endemic goiters, all the guys who are going to have the endemic goiter, that is because of the reduced iodine intake. So they basically take the food or the plants which are grown in a iodine deficient soil. Hilly areas downstream of the water, iodine gets washed away. Whatever grows in those areas are going to be iodine deficient status, right? So this is what is going to cause your endemic goiter state. So let's understand that why or how the goiter or the gland is going to enlarge. Now this is the most important point or the thing to be remembered. What is the pathophysiology? What is the pathophysiology of goiter? So when I say the pathophysiology of goiter, again we have the same circuit. We'll reconstruct a circuit that we know. What do we know? We have the high command. The high command is your hypothalamus. The high command is your hypothalamus. The hypothalamus is going to tell the pituitary gland to work. The pituitary gland is now going to tell the thyroid gland to produce T3, T4, right? If I complete the circuit, you will notice that the hypothalamus, which is present here, this is the pituitary gland. This happens to be the thyroid gland. Hypothalamus tells the pituitary gland by releasing the thyrotropin regulating hormone कि भाई काम कर ले, ठीक है. Pituitary gland बोलता है ठीक है मैं TSH बनाता हूँ, TSH बोलता है thyroid gland को कि भाई काम कर ले, है ना. तो एक के बाद एक काम डिस्ट्रीब्यूट किए जा रहे हैं. हाइपोथैलेमस ने बोला पिट्यूटरी कि भाई काम कर ले, ठीक है. पिट्यूटरी ने बोला कि थायराइड ग्लैंड को कि तू भाई काम कर ले. पिट्यूटरी ग्लैंड बोलता है ठीक है मेरा काम ही है काम करना, तो मैं काम करूंगा. तो जितने भी आपके थायराइड फॉलिकल्स हैं, ऑल दीज थायराइड फॉलिकल्स व्हिच आर प्रेजेंट, they are now going to get stimulated by TSH. So hypothalamus releases TRH. TRH stimulates the thyroid follicle, pituitary gland. It releases TSH. TSH stimulates the thyroid follicles, and when the thyroid follicles are stimulated, they are now going to release T3, T4. They are now going to release our T3, T4, and when the concentration of T3, T4 in the body becomes adequate, when the concentration of the T3, T4 in the body becomes adequate, it is now going to trigger the negative feedback. Now we have discussed negative feedback is not a bad feedback. It tells you that there is an adequate amount of T3, T4, so they can stop synthesizing the hormone, right? So this is the basic cycle that is going to be present, right? So it starts from the hypothalamus, pituitary gland, thyroid gland, T3, T4, negative feedback, and it stops. One important thing that we forgot, that the entire cycle will only run as desired if the iodine supply remains normal. So this whole cycle can only run as per what we desired if the iodine supply to the gland remains normal. Now let it say a primary iodine deficiency or a secondary iodine deficiency, we don't know, whatever it is, if the iodine supply is less. Now this decrease in iodine supply can be because of primary iodine deficiency, secondary iodine deficiency, anything. So what is going to happen? Now because the iodine supply is less, the T3, T4 production. So what is going to happen? You will notice if the iodine supply is less, what is going to happen to the T3, T4 production? This is going to decrease. Now if the T3, T4 production decreases, it is now going to stimulate the hypothalamus. Stimulating the hypothalamus will produce more amount of thyrotropin regulating hormone. It will stimulate more pituitary gland, so hence the TSH will increase more. Now as the TSH production will increase more, there will be more amount of TSH that will going to reach down to the thyroid follicle. We have learned in our basic physiology class that whenever the TSH hormone is going to be produced, TSH has two basic functions. One is to stimulate the thyroid follicles, another one is to promote growth. It can only promote growth when it is in excess form. Now the TSH has, it is in excess form, so what is going to happen? This excess amount of TSH is now allowing the thyroid follicles to proliferate. Now this excessive amount of TSH, when it is produced, it will cause the proliferation of the thyroid follicle, and this excessive proliferation of the thyroid follicle throughout the gland, this excessive proliferation of the thyroid follicles throughout the gland will make the gland to enlarge. Now when the gland gets enlarged, you see the entire follicles within the glands are going to become enlarged. Now this enlarged follicular status, you see this gland, because all the follicles are getting enlarged, you will now notice the entire gland is going to enlarge. This entire gland is going to get enlarged because of the excessive amount of TSH which has caused all the follicles, to expand. So it is promoting growth in the form of both hypertrophy as well as hyperplasia. You know, all the follicles which are present in the gland has now proliferated under the influence of TSH, and hence enlarging the gland. So gland which is this small has become this big because of excessive amount of TSH. Now that is why this condition is what we call it as diffuse. This is what we call as diffuse hyperplastic. This is called as diffuse hyperplastic goiter. Now it is called diffuse because the entire gland, hyperplasia, that is increase in cells, obviously follicular cells have proliferated and causing a uniform enlargement of the gland, hence the name goiter. So this is what we call as diffuse hyperplastic goiter. So the first form of the goiter is going to be the enlargement of the thyroid gland because of this excessive amount of TSH under the influence of this negative feedback pathway, which is now causing an over proliferation of your thyroid follicles, resulting in an enlarged gland, and this is what we call it as diffuse hyperplastic goiter. Now you need to understand a very basic concept, that this iodine is like a raw material. I can give an example like a sugarcane machine, right? The machine is running, right? The machine is running. No matter how much you run, if you don't put the sugarcane inside, you will not get the juice. Same way, no matter how much amount of this axis is running, how much amount of TSH is going to increase, it doesn't matter. If there is no iodine supply, T3, T4 cannot be present, or it cannot be formed. Body is trying to push more amount of TSH, or though. It's like machine or gumao. But ganna dial nahi raho. In the same way, when you're trying to give more amount of TSH, when there is no iodine supply, there will be no T3, T4, and that decrease in T3, T4 will cause overstimulation of TRH, more TSH, and hence causing the proliferation of the gland, resulting in diffuse hyperplastic goiter. Did you all understand this? Did you understand how the gland is getting enlarged? Now the good news is this diffuse hyperplastic goiter is a reversible state. Diffuse hyperplastic goiter, it is a reversible. This is a reversible condition. That means if I give iodine supplementation and if I give the hormonal supplementation, the gland will regress back to its normal. I don't need to do anything great about it, right? Isn't that amazing? The body says, okay, I'll give you a chance. You give me the iodine back, you give me the hormone back, it will regress back to its normal. So it's like you're removing the stimulus that you have created. Now, let's say if patient says, screw it, I'm happy, it's just the gland, it is not causing any problem, I can go and come and do my daily work, and patient continues to ignore. If patient continues to ignore, what can happen? Now the fate of this gland, which is diffusely enlarged, can transform immediately. Now what is that transformation that you're looking at? Now you say that these are all the follicles that have proliferated. Now obviously when the proliferation is going to occur, not all the follicles will be equally active, right? So there will be some follicles which are more active, there are some follicles which are less active, and whenever the follicles are going to proliferate, obviously their activity will also vary a bit. So there will be few follicles which are going to be very active, there will be few follicles which are going to be less active. So what is the problem? The problem is next time when the TSH hormone is going to come. So this is our TSH hormone. The TSH guy is walking towards you. This is our TSH guy. Now as the TSH guy is walking towards the thyroid follicles, so all the thyroid follicles are saying, come to me, 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 come to me. So it is like, this is that hotshot bachelor, right? And all these girls want him to come to him, right? Now whichever is the prettiest one, obviously is going to go down to them. Let's say there are few more guys, right? So the number of guys who are walking towards these girls are obviously lesser in number when compared to the number of girls available. So it is obviously possible that not every girl is going to get a guy. So what is going to happen? Whoever gets it, they remain activated. Whoever gets it, they all remain stimulated, and whoever doesn't get it, they become dormant. So there will be few follicles who will become less active, and there will be few follicles who will be more active, right? So whichever follicles are going to get more amount of TSH, they will start to proliferate more, and whichever follicles are not active or they are not able to compete for the TSH, they will become dormant. Now, in this scenario, I can say few of the follicles, they are turning dormant, and few of the follicles, they remain active. Now it's a common sense that if the dormant follicles are there, they are not going to be acted upon TSH, they cannot enhance, they cannot proliferate. On the other hand, the one which is active will continue to proliferate. Now as it continues to proliferate, you will now notice the gland is now going to become a bit distorted. You will see the gland is going to become a bit distorted. Why it is going to become bit distorted is the follicles which are inactive, the follicles which are dormant, they will not be able to proliferate. So they are here the dormant dead follicles which are present. Those follicles which are able to proliferate, they now over proliferated. So there's a differential growth, right? Few follicles, they are not even proliferating a bit. Few of them are going to proliferate more. So this uniform enlargement was initially seen is now going to convert into this differential enlargement. So follicles which are active, they proliferate more. Follicles which are not active, they become dormant. Now this diffuse hyperplastic goiter, until this point we had a patient with diffuse hyperplastic goiter. We had a patient with a diffuse hyperplastic goiter is now converting, you can see, because of differential stimulus into multinodular goiter. Is now converting into the multinodular goiter. And remember, these multinodular goiter is an irreversible condition. The multinodular goiter is an irreversible condition. It's an irreversible condition. The follicles do not choose to be active or do not choose to be dormant. It is more about the competition. Whichever, because the amount of TSH coming will be in a limited quantity, even though it is increasing. So the follicles which are proliferated are much more in number when compared to the amount of TSH coming. So they are going to compete for TSH. Whoever gets the TSH, they remain active. Whoever cannot get TSH, they remain dormant. Okay? Clear? So the nodularity is because whichever part of the follicle they are able to proliferate more when compared to the rest of them, they will cause differential growth, and that differential growth is going to result in nodularity. Another very important concept where how this can turn into nodularity or it can form into nodularity, another reason that I can give you is, let's say the same context. Okay? Another reason why the nodules can be formed, we will take the same example of the diffuse hyperplastic goiter. Let's say this is the diffuse hyperplastic goiter is there. So in the diffuse hyperplastic goiter, we have all the follicles which are uniformly enlarged. Okay? Now imagine that these are the follicles which are uniformly enlarged, and this is your diffuse hyperplastic goiter. Now as in diffuse hyperplastic goiter, there will be hyperplasia that is going to occur. So whenever there will be hyperplasia, obviously it will require more blood supply because new cells are formed and new cells require blood supply. So hence there will be a lot of vascularity that you will see in this point also. So these follicles which are proliferated would have the vascularity. You will see vascularity is more common in the toxic swellings, but here also in goitrous, because of hyperplasia, there will be blood supply which is increased than the normal one. Okay? Any hyperplasia, new cells require nutrition. That nutrition is going to be complemented by this blood supply. There could be, see, all these new blood vessels are formed, they are very friable, they are very weak. So there can be a spontaneous rupture. Apart from spontaneous rupture, there could be a minor trivial trauma. Somebody has touched it, somebody has hit it. So whenever that happens, a few of these blood vessels can burst open. So when they burst open, they will cause hemorrhage. There will be a sudden hemorrhage in the center. So the supply of the blood comes from the center. So you'll see the central hemorrhagic core is going to be formed. Now as it is a bleed, what is going to happen? There will be a massive hemorrhage, and this hemorrhage is going to expand immediately. Now this hemorrhage, when it expands, no, patient will experience pain also, there will be some increase in size also. All this is noticed, but more importantly, all the active follicles are now pushed into the periphery. The central hemorrhagic core takes away, and all the active follicles are now pushed into the periphery. So there's a central hemorrhagic core, and the active follicles are going to be pushed into the periphery. Next time when the TSH hormone is going to come, these glands or these follicles are going to proliferate. So look at the status of the proliferation here. You will see this is the thyroid gland. So this is how the gland would look like. So the area where you have the follicles in the peripheral rim, when the TSH acts on them, they will proliferate. When they proliferate, obviously they will enlarge. In the center, the hemorrhage which is present, no, that hemorrhage will convert into a necrotic core, and that necrotic core will convert into fibrosis. So there is a peripheral rim of active tissue. Because in the central there was hemorrhage, and that hemorrhage is now transformed into necrotic core and then eventually getting fibrosed. Now all you intelligent people who are listening, tell me, fibrosis is a reversible state or a irreversible state? Fibrosis, if it happens anywhere in the body, will it remain reversible or will it become irreversible? Fibrosis reversible or irreversible? Obviously it is irreversible. Now you see the gland at certain areas is becoming more enlarged when compared to the other areas. So it is becoming nodules. That nodules is because of differential stimulus. Now that differential stimulus can also be because of hemorrhage. So this is also a form of multinodular goiter. So why does the nodules form? Initially the patient had a nice diffuse hyperplastic goiter. Now that diffuse hyperplastic goiter is converted into a multinodular goiter if it is not treated. Why does that happen? It happens because of two reasons. Either there is a differential stimulus, few of the follicles become active, few of them remain dormant. The active ones continue to take TSH, they proliferate more when compared to the surrounding ones. The one we are not getting the TSH, they suppress, they become atrophic. When they become atrophic, they again become in a differential growth status. That differential growth can also result in multinodular goiter. Another reason a multinodular goiter can happen is because of this spontaneous hemorrhage pushing all the active cells into the periphery, and that active peripheral cells, when they proliferate, causes a differential growth, and that differential growth will result in multinodularity. Okay? Clear? Clear, guys? Did I make sense out of it? Bhai bolo. So these are the concepts where you will be asked repeatedly in your words. Exactly, Snehajit, you are absolutely correct. Now, because it becomes an irreversible status, and long-standing goiter, if it is untreated, is a risk factor for development of follicular cancer thyroid. I don't want my patient to go into that state where he is subjected to malignancy. To prevent that, I would operate on these patients. I would not operate on diffuse hyperplastic goiter. This is reversible. I'll give him iodine, it will take care of the gland. But once it becomes this, there's no coming back from here, so I have to go and operate, right? Mohammad Basam, don't worry, हम बताएंगे कि कैसे differentiate करोगे हम, है ना? Don't, jump. पहले एक एक करके चलते हैं. अभी बन गया goiter, ठीक है? So we'll try to understand that once the goiter is formed, how the patient present to us. So we'll talk about the clinical presentation of people presenting to you with goiter. Okay. Usually, the usual age of goiter that is seen is between third decade of life. So it is between 30 to 40 years. It is more common in females when compared to males. If it is an endemic one, then I would say there is equal chance for both males and females. But otherwise, it is more common in females. Again, a very commonly asked question, why females are more commonly affected in thyroid disorders when compared to males? A simple explanation that you have, that the thyroid follicles or the thyroid follicular cells have the estrogen receptor on themselves. So because of the estrogen receptor status which is present on the thyroid follicular cells, the estrogen level in the body of the female keeps on fluctuating throughout its life, during the menstrual cycle, during the pregnancy, post-pregnancy, during the menopause. Every time there is fluctuating, and that fluctuant status of the hormone keeps the follicles to also get fluctuatedly stimulus, and that will result in development of the thyroid disorders, more common in females, right? Okay. Now, how the patient present you? What is the classical complaint? The classical complaint of these patients, the patient will land up to you with presence of midline neck swelling. The patient will complain about midline neck swelling. Okay. Now, this midline neck swelling, it is usually going to be painless. It is going to be painless. So the first complaint, patient will come to you in the OPD and patient will say, Doctor Saab, there's a swelling which is present here and this swelling has been there for a while. Okay? So it's a midline neck swelling. It is going to be painless. Now it is our job to evaluate this midline neck swelling which is painless. Right? Rahul, multinodular goiter need not be hyperthyroid in status. That is because of secondary thyrotoxicosis. We'll talk about it. Okay? See, toxic swellings are a different spectrum altogether. When we say simple goiter, so today we are dealing with the topic which is called as a simple goiter. So when we say the word simple goiter, so here the goiter that we're dealing today is an example of a simple goiter. वैसे कुछ simple होता नहीं है, नाम बोलने के लिए simple है. Simple goiter में the word simple basically means the patient is either euthyroid or hypothyroid. The word simple means either the patient is euthyroid or whether the patient is hypothyroid. Either it is a euthyroid or a hypothyroid status. Okay? Either it is a euthyroid or a hypothyroid status. That's what it means. Okay? So when we have a patient who has walked up to your OPD and you're sitting, simple means relatively harmless. Again, लॉन्ग स्टैंडिंग गॉइटर कैन कॉज कैंसर, उससे ज्यादा क्या हार्म हो सकता है. ठीक है, तो ऐसा सिंपल बोलने के लिए सिंपल है, लेकिन सिंपल सिंपल कुछ नहीं होता. राइट? सो लाइफ इज कॉम्प्लिकेटेड, एवरीथिंग इज कॉम्प्लिकेटेड. यू नीड टू थिंक सिंपली टू गेट अ कॉम्प्लिकेटेड आंसर. ठीक है, अब ज्यादा उसके नीचे नहीं जाएंगे. ठीक है, अब बाल की खाल नहीं नोचेंगे, हम गॉइटर पे रहेंगे. ठीक है, सो वी हैव अ पेशेंट. इमेजिन करिए यू आर सिटिंग इन एन ओपीडी एंड द पेशेंट वॉक्स अप टू यू, से डॉक्टर साहब प्रॉब्लम है. व्हाट इज द प्रॉब्लम? ये देखो इतना बड़ा स्वेलिंग हो गया है. ठीक है, ग्रेट. Now you have a patient with a midline swelling in the neck which is relatively painless. तो क्या करेंगे? उसको हम examine करेंगे. I said okay, on examination what are the different findings that we are going to get. लेकिन examination करने के लिए you have to do something. No, what are the positions in which you would like to examine? So remember, I will examine in a sitting position. I will examine in a sitting position with adequate exposure of neck. With adequate neck exposure. यही prerequisite है thyroid gland के examination का. So I will ask the patient to sit on a stool and with an adequate exposure of the neck. Now ये सवाल बहुत famous है कि in which position should you examine a certain swelling. ठीक है, I'll give you a very simple logic and a concept to remember. Any swelling that is present above the level of Ziphy sternum. ठीक है, ये मेरा Ziphy हो गया. ठीक है, any swelling that is present above the level of Ziphy sternum, let it be a breast swelling, let it be an axillary swelling, the upper limb swelling, the head and neck swellings, all these swellings should be examined in a sitting position. All your abdominal swelling should be examined in the supine position. All your inguinoscrotal swellings should be examined in a standing position, even your varicose veins. ठीक है, बड़ा सिंपल है. कोई भी swelling जो Ziphy sternum के ऊपर है हम बैठ के एग्जामिन करेंगे. कोई भी swelling जो एब्डोमेन में हम लेट के एग्जामिन करेंगे. कोई भी, हम नहीं लेटेंगे, पेशेंट को लेटाएंगे. कोई भी swelling which is present in the inguinoscrotal region, उसको हम standing position में एग्जामिन करेंगे. तो हर्निया का एग्जामिनेशन का बेस्ट कंपोनेंट क्या है? It is going to be in standing position, right? In the same way, thyroid, sitting position, parotid swelling, sitting position. ठीक है, you're talking about breast swelling, sitting position, mass abdomen, supine position. We're talking about hydrocele, again it is a standing position. So all these swellings which are present, so we have divided. No, anything above the level of Ziphy sternum, it is going to be sitting position. Anything which is in the tummy, that is in the abdomen, is going to be supine position. Inguinoscrotal swelling is going to be in the standing position. So let's say how we are going to examine these patients. We'll take a quick we'll take a quick feedback on this also. So let's say, I'll show you my patients also, but before that I'll give you a cartoon approach to this. Let's say this is the round stool that we have. I will tell you about 3 positions in which you would examine a thyroid swelling. So we can examine the thyroid swelling patients in 3 different positions. Now the first position that you would like to examine is going to be called as the Lahey's position. So what you're going to ask is, you are going to ask your patient to sit with the extension of the neck. So this is the patient. I'm asking the patient to extend the neck and sit. So patient is sitting, and this time I'm asking the patient to put the hands by the side. Okay. Now you can go and stand behind the patient. You can go and stand behind the patient. Put your hands around the patient's neck. Use all your fingers to feel the thyroid swelling. Right? Now, if you go behind and put your hand and palpate the thyroid swelling, or in front also if you're using the entire hand, this is what we call it as the Lahey's method of examination. This is what we call it as the Lahey's method of examination. Okay. Achha. We have another patient. Again, this time the patient is short and obese neck. So I want the extension of the neck to be as much as possible. So I'll ask the patient to put the hand behind the head. Now you'll ask the patient, so this is in this method, you'll ask the patient to put the hands behind the head and throw the head against your hand. Now how do you ask the patient? You see here, you ask the patient to cross the fingers, put it around your head and then flex it. And when the patient is flexing the head, you have to give the traction. So ask the patient to give the traction with the hand so that there is that amount of pressure that can be generated. Okay? So you clasp the fingers, put it across here, and then you go stand behind the patient. You go and stand behind the patient and examine the patient in the same way that we did. Right? Now this method where you're asking the patient to clasp the fingers behind the head and throwing the head, this is what we call it as the Pizzillo's method of thyroid examination. This is what we call it as the Pizzillo's method. This is what we call it as the Pizzillo's method. This is what we call it as the Pizzillo's method of the thyroid examination. Now, important thing about the Pizzillo's method, this is done for the patient who have short, stout and obese neck. Patient who is going to have a short, stout or the obese neck patients. A short-statured or short-necked or obese patients, whoever have these stages, you're going to go ahead with Pizzillo's method. The last one, which is going to be done, it is about to assess the nodularity of the gland. Again, this time the patient is all fine. You'll ask the patient to sit. Put the hands across here. You'll go stand in front of the patient. And this time, I'm going to use my thumb. So I'm going to anchor with one hand, use the thumb of the other hand, and to examine the thyroid swelling. So I'm using the thumb here. This is the rest of my hand. I'm using the thumb, which is going to be here, and you have the thyroid swelling which is present here. So in this thyroid swelling, I am using the thumb to palpate this swelling. I'm using the thumb to palpate this swelling, and this is what we call it as the Crile's method. This is what we call it as the Crile's method. Now the Crile's method is to assess the nodularity of the gland. It is to assess the nodularity of the gland. So we have three basic methods of positions. Three basic methods of position in which you would like to examine the thyroid gland. One is Lahey's method, where you put, patient is sitting in front of you, you put your hands and try to palpate it. Okay? Pizzillo's method, it is for patients who have a short and a stout neck. छोटा neck है, stout neck है, तो ये दिख नहीं रहा. देखो ऐसे neck है. अगर ऐसे neck है तो कैसे एग्जामिन करोगे? मुश्किल है. तो हम क्या करेंगे? पेशेंट को बोलेंगे कि पूरा करो, लेकिन पूरा करने पे भी नहीं हो रहा है, तो क्या करेंगे? इसको ऐसे एक्सट्रैक्शन दो. Now when the patient tries to push the head, no, now this part of the neck is getting more exposed. So this exposure I want. ठीक है, तो इसको बोलेंगे कि हाथ पीछे रखने का, दोनों को क्लैस्प करने का और पूरा नेक पीछे छोड़ देने का. जब वो करोगे ना, this hand will give the grip to the head, supports the head, allows for the extra extension of the neck so that you can examine, and this is your Pizzillo's method. Crile's method में क्या करना है, अंगूठा ऐसे रखना है और बोलना है घोटो. When the patient swallows, the gland moves. You put your thumb here, the gland, ये gland है. When the patient swallows, the gland is going to move up and down. You put your thumb, and when the gland moves up and down, it will rub against your thumb. Don't move your thumb. Thumb is here only. The gland is going to move up, down, up, down, up, down, up, down. So you will know whether the gland is smooth or there is nodularity. अगर smooth है तो diffuse hyperplastic goiter is a possibility. लेकिन अगर nodular है तो obviously it is multinodular goiter. आई बात समझ में? ठीक है. So you have the Lahey's method, the Pizzillo's method, and the Crile's method. पूछ पूछ के थका देते. यही 3 methods है यार. ठीक है, ज्यादा इसमें कोई झोल नहीं है. इट्स अ वेरी सिंपल थिंग दैट हाउ यू आर गोइंग टू कॉम्प्रिहेंड दैट हाउ डू यू एग्जामिन Lahey's मेथड, Pizzillo's मेथड एंड योर Crile's मेथड. पूछ लेगा इतना, क्या पूछेगा, मोस्ट कॉमन मेथड इज योर Lahey's मेथड. फिर पूछेगा शॉर्ट स्टेचर्ड पेशेंट है, ओबीस नेक है, क्या करोगे, Pizzillo's मेथड. फिर पूछेगा कि नॉडुलैरिटी एसेस करने के लिए कौन सा मेथड यूज करोगे, आप बोलोगे Crile's मेथड. बात खत्म ना यार, इससे ज्यादा और क्या ही पूछ लेगा. ठीक है, सो दिस इज हाउ इट इज गोइंग टू बी एग्जामिन्ड. एक बार एग्जामिन कर लिया, नाउ वी हैव टू सी. Once the examination is done, now we have to assess what are the examination findings. Okay? Now, on a clinical examination, when you take the history, you will know that this is gradually increasing in size. There's an exception that this can also have sudden increase in size. That sudden increase in size in a goiter, it is due to hemorrhage. We've just learned it, that sudden increase in size, it is due to hemorrhage. Snehajit, in a Crile's method, you need, because swelling is evident, you just need to feel for the nodularity. We have a video of the patient, दिखा देंगे clearly कि कर क्या रहे हैं. ठीक है, कोई टेंशन नहीं है. So gradually increasing in size is the norm, but there can be sudden increase in size, and that sudden increase in size is because of hemorrhage. As I told you that this swellings usually remain painless. So when you palpate, no, there will be no tenderness. So it is non-tender. Now the only time the patient will experience pain, so the pain is present. Again, this is also due to hemorrhage. So when there is a hemorrhage inside the thyroid follicle, or I can say in the thyroid gland, that hemorrhage will cause both sudden increase in size as well as it will cause the component of pain to be there. So there is gradually increasing in size, it remains painless, which is also going to have a non-tender status. Okay? So you have a patient who is going to have gland which is gradually increasing in size, it remains painless, it is going to be non-tender. It is going to be non-tender, right? Now, how do you know it is a thyroid swelling? We have already spoken that this is going to be a swelling that is going to move upwards with deglutination. We have already dealt with the fact that the movement of deglutination of a thyroid gland is because of a good friend, that is Berry's ligament, that is attaching to the pretracheal fascia, which is continuous with the cricopharyngeal junction, which moves up. So the gland also moves upwards. So it moves upwards with deglutination, right? It will also tell you that on palpation, when you palpate, it will tell you whether it is going to have a smooth surface, whether it is going to have a smooth surface, or whether it is going to have a nodular surface. Now my question to you is, if there is a smooth surface, what phase or what stage of goiter do you think the patient is in? And if it's a nodular surface, what stage of goiter do you think it is? As a simple question. Okay? If there is a nodular status, I know I am dealing with multinodular goiter. So presence of nodularity confirms it is a multinodular goiter. But if you have a smooth surface does not confirm that the patient is having a diffuse hyperplastic goiter. Why I am telling you this? If a patient is having a smooth surface, no, you cannot confirm the patient having a diffuse hyperplastic goiter. The reason is, in order for the nodule to be palpable, it should be a minimum of 10 millimeters, that is 1 centimeter. A nodule lesser than 1 centimeter is very difficult to palpate and appreciate. Point number 1. Point number 2, if the nodule is too small and it is inside the parenchyma, it is not on the surface yet, you will not be able to appreciate it. What if it is present on the posterior surface of the thyroid gland? Can you appreciate clinically? The answer is no. So clinically, if the surface is smooth, that does not confirm it is diffuse hyperplastic goiter. I can say it can be both diffuse hyperplastic goiter or it could be multinodular goiter. So I don't know clinically, or I can't really confirm it whether you have a diffuse hyperplastic goiter or a multinodular goiter, right? So this is the status that you will find in these patients. So gradually increasing in size, it remains painless, it's a non-tender swelling, it moves upward with deglutination, it might have both smooth surface or the nodular surface. Now if patient continues to ignore, patient बोलता है जाना ही नहीं है, doctor क्या doctor छोड़ो, as long as it is there, it is there, it is not causing any problem, patient continues to ignore, so he might land up with complications. So what are the complications that you can expect with the goiter? Now the complications that I can expect with the goiter, number 1, in a long standing goiter, a long standing goiter can result, especially large one, can result in tracheomalacia. Now this tracheomalacia basically means tracheal weakening. This is called as tracheal weakening. Now the basic concept behind this is, let's say this is the trachea that we have, right? Let's say this is the trachea that is present and it is in this particular context, right? These are the tracheal rings which are present, which are formed in this particular manner, right? Now you see the thyroid gland initially was of this size. Okay? When it was this size, it was not causing any problem. Today, the thyroid gland has enlarged. Now this enlarged thyroid gland is going to exert more pressure onto the trachea. So this is the enlarged thyroid gland. Now this enlarged thyroid gland is going to exert more pressure onto the trachea. Now as it is exerting more pressure onto the trachea, it will have pressure symptoms, but more importantly, what will happen to the tracheal rings, the cartilaginous rings which are present? Now as there is a constant amount of pressure, it is the weight that is being pushed onto the trachea, especially when the patient lying on supine. No, this entire enlarged gland is going to compress the trachea. Now it is like that rubber band effect. Okay? I give you a new rubber band, I ask you to stretch, leave it, it will recoil immediately. But I ask you to stretch on a daily basis and I come back after 30 days. Let's say after 1 month, what will happen to that rubber band? It will become weak and soggy. Same way, the gland is exerting pressure on the trachea on a daily basis. Over a period of time, the trachea becomes weak and soggy. And that weak, soggy trachea, because of the constant pressure caused by the thyroid gland, is what we call it as the tracheomalacia. This is what we call it as the tracheomalacia, right? So this is what the gland is exerting the pressure on, and this exertive pressure over a period of time is what we're calling as tracheomalacia. The trachea is becoming weak, softened, right? Now how do you know clinically that the patient is having tracheomalacia? ठीक है, gland compressed है, थोड़ा बहुत deform हो गया, ठीक है, a little bit of deformed trachea is noticed, right? There's a little bit of trachea which is getting deformed. I understand, okay fine, trachea is deformed, but how do you clinically know that the trachea is deformed? मेरे को यहाँ तक तो हो गया, ठीक है, gland enlarge हो गया, दबा दिया, trachea is getting deformed, but I need to know clinically that how do you know the trachea is getting deformed? For that we have a test, and the test is what we call it as the Kocher's test, ठीक है? तो इसको देखने के लिए हम करेंगे Kocher's test. We do a test which is called as the Kocher's test. Kocher बोलता है बड़ा simple है. Kocher says it's quite simple. All that you have to do is take your hand, exert the pressure on the trachea from the lateral side, from any other side, and see what is going to happen. So when you exert the pressure onto the trachea from the lateral side, let's say you're exerting a lateral pressure on the trachea. Now because you're exerting the pressure on the trachea is going to become even more compressive. the trachea is going to become even more compressive. The reason it is going to become even more compressive because it is fecund, it is tracheomalacic, and you see the thyroid gland which is being counted here, which is here. So you have exerted the pressure laterally and you are compressing the trachea. So the trachea is becoming, okay, I'll take the gland out. The trachea is becoming quite narrowed down. It is, so for you and me, if I exert the pressure here, I exert, see, look at my trachea right inside. I exert the pressure, the trachea just moves onto the opposite end. The trachea moves onto the opposite end. For that patient, when you exert pressure, no, the trachea does not move, it compresses, it collapses, it becomes narrow. And then I'll ask the patient to breathe. I'll ask the patient to take a deep breath. So what is going to happen? As long as the lumen remains uniform, the flow will also remain uniform. But the minute the lumen is going to become irregular, you will see the flow of the air will also become irregular. There will be a turbulent flow that is going to form. And the flow, if the flow becomes turbulent, what is going to happen? During inspiration, I will be able to hear this noise. And this is what we call as presence of inspiratory stridor on exerting lateral pressure on trachea. On exerting lateral pressure on trachea is what we call it as the Kocher's test positive, right? So if you exert pressure from the lateral side and you see the trachea is getting compressed, and ask the patient to breathe, and during that inspiration, this presence of inspiratory stridor, I know there is presence of tracheomalacia. Now the reason is, if you operate on a tracheomalacic patient, the post-operatively trachea will collapse. You should not allow you to do that. So hence, counter the tracheomalacia before you operate. But clinically, how do you know there is a tracheomalacia? Do a Kocher's test positive. And whenever there is a tracheomalacia and you do an X-ray, in an X-ray, you will find the trachea is getting all compressed, the lateral compression and all the compressed trachea will give a very classical look, which is called as the scabbard trachea. You have heard about the scabbard trachea. So what is the scabbard? The word scabbard comes from the component that it is the shell in which the knife is kept. In which जो म्यान बोलते हैं ना, म्यान को हम बोलते हैं scabbard. So knife is kept inside this. So the outer covering of this knife is what we call it as scabbard. So this indicates the trachea is becoming like this. This is a compressive trachea. So we call it as scabbard trachea. So the first complication that we can talk about is about the tracheomalacia. And this is the whole story about the tracheomalacia that you can see, right? So this is about the long-standing goiter can result in tracheomalacia. Another problem that a long-standing goiter can also result, that it can cause pressure symptoms. It can result in development of pressure symptoms, right? Now, what is this pressure symptoms, right? Again, we'll not try to memorize anything. We'll try to understand logically. To understand the pressure symptoms, you see this is the trachea that is present. These are the tracheal rings that we have. Behind the trachea, we have our esophagus. So this is the esophagus. In between them, there's a tracheoesophageal groove. Behind this, you have the vertebra. So let's say this is the vertebra that is going to be present. It's a bony space. No, it is not going to budge. So this is the vertebra that is present. This is the vertebra that is going to be present. Now, when the gland is going to enlarge, initially, let's say the gland is only this much, right? There's no problem. But when the gland enlarges in size, it is now going to exert pressure on the underlying structures. So what are the underlying structures do we have? The underlying structure is going to be trachea. The underlying structure is going to be trachea. It is going to compress the trachea. The pressure will transmit onto the esophagus. The esophagus is also going to get compressed. And between these two, you have this a nerve that is running. That is your recurrent laryngeal nerve in the tracheoesophageal groove. So because of this enlarged gland, it is now going to compress these three structures. It will compress the trachea. It will compress the trachea. It will compress the recurrent laryngeal nerve. It will also compress the esophagus, right? Compression of the trachea will result in difficulty in breathing, and that is what we call it as dyspnea. So patient will present to you with dyspnea. Compression of the recurrent laryngeal nerve will result in hoarseness of voice. It will result in hoarseness of voice, and this is on the recurrent laryngeal nerve. And if there is compression of the esophagus, this will result in dysphagia. So you have dyspnea, hoarseness of voice, and dysphagia. These three symptoms put together is what we call it as pressure symptoms. These three symptoms put together is what we call as pressure symptoms. Now I hope you understand what is the basic concept behind the pressure symptoms. Is that clear? Okay. So we have two complications. One is a long-standing goiter, which is going to result in tracheomalacia. Another one, it is going to result in your pressure symptoms. Apart from that, what are the other complications that you can look across? The other complications, it will rev up into secondary thyrotoxicosis. Now, what is this secondary thyrotoxicosis? We don't know why, but 30% of the patients, if they have an untreated goiter, suddenly a simple swelling, which why we call it simple, when it's U or hypothyroid, transforms into a hyperthyroid status, and this transformation is what we call it as secondary thyrotoxicosis. It will result in secondary thyrotoxicosis. Apart from that, we already spoke that intrafollicular hemorrhage, which can cause sudden increase in size as well as pain, can also be considered as a complication. It can result in calcification within the gland. It can result in calcification, but more importantly, it increases the risk for follicular cancer thyroid. It increases the risk for follicular cancer thyroid. Currently, the risk stands at 10%. That means those patients who have long-standing goiter which is left untreated, 10% of these patients have a higher risk of developing into follicular cancer thyroid. So what do we have? 1, tracheomalacia. 2, pressure symptoms. 3, secondary thyrotoxicosis, hemorrhage, calcification, and increased risk for follicular malignancy. Increased risk for follicular malignancy. Right? So, patient came to you. You took a nice clinical history. You spoke about the patient. You did a clinical examination. Now you have a provisional diagnosis of whether it is a diffuse hyperplastic goiter or a multinodular goiter. How do we approach this patient? So in terms of investigation, how would you like to investigate? Now, any thyroid swelling, the first investigation has to be a thyroid function test. You have to send the ultrasound of the gland, and if on a TFT, patient has a status of euthyroid or a hypothyroid. I repeat, if it is U or hypothyroid, also take an FNSE to rule out malignancy. Right? If it is a hyperthyroid, I don't need to take any biopsy or any FNSE because toxic swellings are usually not malignant. It is either a U or a hypothyroid swellings which are going to be usually malignant. So once you confirm on a TFT the patient is U or hypo, on an ultrasound you have to see whether it is a diffuse hyperplastic goiter or whether it is a multinodular goiter, because ultrasound is the only investigation that can purely differentiate between whether it's a diffuse hyperplastic goiter or whether it is a multinodular goiter, and FNSE is basically to rule out malignancy. It is to rule out malignancy. Now once you have made the diagnosis, the management depends whether you have a patient who is going to have a diffuse hyperplastic goiter or whether the patient is having a multinodular goiter. We all know diffuse hyperplastic goiter is a reversible state. It is a reversible state, whereas multinodular goiter, it is irreversible. It is irreversible. Now, if it is a reversible state, the simple logic says start the patient on iodine supplementation. Start the patient on iodine supplementation and give T4 support, that is thyroxine. Usually, the swelling will revert back to normal. Snehajit, ultrasound will tell you if the entire gland has a uniform consistency, it is going to be diffuse hyperplastic goiter. If you see there is differential consistency, there is differential growth, the nodularity will have different density also. That indicates there are multiple nodules present, because fibrotic tissue will have a different density, a follicular tissue will have a different density, the hemorrhage will have a different density, and if it is a dormant follicle which is filled with colloid, will have a different density. So the differential tissue component present in a single organ will tell you whether it is going to be nodular or non-nodular. If it is an irreversible, that is multinodular goiter, I have to say that whether you have to see or complement, is it involving one lobe, that is it is a unilateral condition, or whether it is a bilateral condition. Now what do you mean by unilateral condition is, you see if there is nodules which are present only in one of the lobe, the other lobe remains normal, or whether both the lobes are involved in nodularity. Now if it is only one lobe is involved, so I am going to remove this side of the lobe along with the isthmus, and this is what we call it as lobectomy. So lobe plus isthmus is called as lobectomy. If you remove only lobe, it is called as total lobectomy. We'll talk about it in thyroid surgeries. If it is bilateral, I'm going to remove the entire gland. So here we will do a total thyroidectomy. So whenever you do any patient with total thyroidectomy, there's a dictum that I am going to give this patient a lifelong thyroxine. I'll give a patient this lifelong thyroxine because there is no other form a patient can synthesize the hormone. To supplement that, we have to give a lifelong thyroxine. Post lobectomy also we give thyroxine, but then later on we are going to wean this off once it is going to be compensated. Okay. So this is how you're going to treat your patients of goiter. Clear? Now clinical videos. Okay. So we ran through the entire concept of goiter in 1 hour. I have told you from end to end that in simple goiter, what are the causes and how are you going to treat them, diagnose them, and look across it. But at the same time, you should also know that clinically how is the voice back on? Can you guys hear me? Can you guys hear me? Can you guys hear me? Walaikum salam. Hi guys. Take care. Great. So this is one of my patient. This was a video that was taken just before the OT. She was all dressed up. I just want you to see the video and tell me what examination of the thyroid we are doing. We have told you three. We have told you about the Lahey's method, the Pizzillo's method, and the Crile's method. I just want you to observe and tell me that what method are we performing in this patient. Okay, watch it here. So I'm asking the patient, yeah, there's the swelling which is, you can see it moves upwards with deglutination. I've put my thumb and I'm asking the patient to swallow, right? Only by using my thumb, I'm asking the patient to swallow, right? What is this method? If you're using the thumb, actually the patient should have swallowed, but she's not swallowing. Snehajit, absolutely correct, beta. It is your Crile's method. Originally, I should have kept my thumb here and asked the patient to swallow. Now, if I put my thumb here and ask the patient to swallow, you see the gland is going to move against my thumb, and I'll see whether there is a nodularity is present or not. This is going to be a Crile's method, right? Now, can you identify what type of thyroid swelling is this? I just want you to look at it and give me a diagnosis. Does it look like a diffuse hyperplastic goiter, or does it look like multinodular goiter? Nothing more than that. You have this patient, you can see here. There's a huge swelling that is present. Okay. The huge, it doesn't look like a multinodular goiter. Does it look like a multinodular goiter? No. See, you can see such a huge swelling, chunky swelling, smooth surface. I don't see any nodularity. It's such a smooth surface. You see, such a smooth surface it is there, right? If you have such a smooth surface, it can only be in terms of diagnosis. If you're picking it up, yes, it is diffuse hyperplastic goiter. I want you to look at this again. Just let's look at it together. The patient is having quite difficulty, because it's such a huge gland, it is compressing, is not able to swallow freely. So it causes a lot of discomfort also. See here, smooth surface. From this side also, smooth surface. I'm asking the patient to swallow. Such a smooth surface can only be seen in diffuse hyperplastic goiter. Yes, when you palpate, small nodules can be missed. To confirm that, you have to go ahead with ultrasound. Okay? With that, I'm signing off for today. Thank you so much for listening. These were the concepts in the goiter. We learned how a goiter is formed. We learned how a clinical presentation of a patient would be. We saw clinical videos. We saw also how to diagnose and how to manage as well. So thank you so much for listening. We'll see you guys tomorrow. Tomorrow we'll talk about the toxic thyroid swellings. For that, signing off. Thank you. Goodbye. Any questions, any queries, you know where to reach me out, right? Where do we get all? One more thing. A lot of students have been asking that where can we get the PDF of all these lectures that we are doing. The PDF of all these lectures are available on my Instagram as well as on my Telegram group. Been sharing on a daily basis. It is called as the surgery guide. So you have a question, reach out here. On the Instagram as well as in Telegram, it is by the name called as the surgery guide. Obviously, you'll find my name there. It is Dr. Sandeep Seeram Reddy. Right. So, any questions, any queries? It is ready with an I. Do not forget it. It is not ready with a Y. It is I. Okay. So, any questions, any queries? Post it down there. I will address it. And let's make learning surgery an incredible journey for all of us. Thank you so much for motivating me to come on a daily basis, and thank you for all the love and support. So with that, signing off. Thank you so much, guys. Goodbye. Take care.